This is a picture test in practical anatomy of the upper limb. You may use the video as a revision for the topic or as a self-assessment tool. For the purpose of self-assessment, you may pause the video and spend your own time to read the question and come up with the answer. Then replay the video to confirm your answer by listening to the comments and explanations. Now I will deal with the shoulder region and axilla. The muscle atrophy indicated by the pointer is found in a 29-year-old patient 4 years after a wrestling injury. Which of the nerves A to E was most likely injured at the time of the accident? Now the muscle atrophied here is the deltoid muscle. If you compare it with the rounded appearance on the other side, deltoid muscle crosses the shoulder joint and it forms the rounded contour of the shoulder, as we can see that on the other side. This rounded contour is owing to the underlying upper end of the humerus. That's why this contour can be also lost when the shoulder dislocates. However, in this case, there is no dislocation of the shoulder, but there is atrophy of the muscle itself. Since the deltoid is supplied by the axillary nerve, then this is the nerve that is most likely injured. Now let's look to find the axillary nerve in the dissection. The axillary nerve is one of the two terminal branches of the posterior cord of the brachial plexus. Here is the axillary artery, and you can see that the cords of the brachial plexus are arranged around the second part of the axillary artery. A good landmark here is to find the shape of the capital letter M. This is the capital M, which can sort out some of the branches of the brachial plexus. So A is derived from the lateral cord of the brachial plexus, and it is the musculocutaneous nerve. It disappears laterally by passing through coracobrachialis muscle. B is located behind the axillary artery, so it is the axillary nerve and leaves the axilla by passing through the quadriangular space. So the answer here, B is the axillary nerve. It is located posteriorly from the posterior cord of the brachial plexus, leaves the axilla through the quadriangular space, and is accompanied by posterior circumflexohumeral artery from the third part of the axillary artery. The other branches here, C is the median nerve, and as you can see, if you relate it to the M, these are the lateral and medial roots of the median nerve, so C is the median nerve. And D is not related to the M, but it's again another branch of the brachial plexus, that is the long thoracic nerve, arising from the roots of the brachial plexus and lying on the lateral surface on serratus anterior muscle. E is another branch of the posterior cord. As you can see it here, it is posterior to the axillary artery, but it continues forwards in front of the ribbon-like tendon, glistening tendon of latissimus dorsi muscle, and which is used as a landmark for this nerve, and then the nerve continues distally into the arm. Injury of which nerves A to C is most likely responsible for the deformity shown in the picture? The deformity is produced by a lower brachial plexus injury. It is less common than upper brachial plexus injuries, and it is also called Klumpke palsy. This results from excessive abduction of the arm, as in during labor, as in this case of a newborn. Excessive abduction of the arm may also occur when a person falls from a height, grasping something to save himself. Note that T1 lesions may also occur because of a cervical rib. In Klumpke's palsy, the first thoracic spinal nerve is usually torn, and thus affecting the lower cord of the brachial plexus. The intrinsic muscles of the hands are affected, since this is the myotome of the intrinsic muscles of the hand, and so the hand looks like a claw due to hyperextension of the metacarpophalangeal joints and flexion of the interphalangeal joints, because of the loss of action of the interossei and lumbricals, which are supplied by the ulnar nerve, which carries fibers from T1 to supply these muscles. There will also be loss of sensation on the medial side of the arm, especially if C8 is also damaged. This is a demonstration of the action of the lumbricals and interossei and what happens when these muscles are not innervated. You will remember that the lumbricals and interossei, they flex the metacarpophalangeal joints and extend the interphalangeal joint. In a claw hand, where the lumbricals and interossei are not in action, there will be the reverse. That's to say, there will be hyperextension of the metacarpophalangeal joint, and there will be at the same time flexion of the interphalangeal joints. Extensor digitorum, which is unopposed by lumbricals and interossei, therefore will produce extension of the metacarpophalangeal joints. Usually, the interossei and lumbricals, they act on the extensor expansion to cause extension of the interphalangeal joints as well. Flexor digitorum superficialis and profundus, unopposed by the lumbricals and interossei, will produce flexion of the interphalangeal joints. Fibers A to C are parts of a single muscle. Identify the muscle and what's the action of each part on the scapula. The muscle is the trapezius muscle. As you can see here, that it is a flat, wide, triangular muscle. It is called trapezius because the muscles of the two sides form a trapezium, an irregular four-sided figure. The muscle arises from the occipital bone of the skull and from the spines of cervical and thoracic vertebrae. It is attached to the lateral third of the clavicle, medial side of the acromion and spine of the scapula, just above the origin of deltoid muscle. The upper fibers here, A, they elevate the scapula, as in shrugging the shoulder, in expressing dissatisfaction or uncertainty. This is the basis for the clinical test for the integrity of the accessory nerve which supplies the muscle. In this case, the patient will be asked to shrug the shoulder against resistance. The middle fibers are more or less horizontal and they retract the scapula. The lower fibers are oblique and more vertical, and so they depress the scapula. An important point here is that if the upper fibers and the lower fibers work together, they will act like a couple of forces that rotates the scapula laterally during abduction of the upper limb so that the glenoid fossa faces upwards. The upper fibers elevate the acromion while the lower fibers, they depress the medial end of the spine of the scapula, and so this results in rotation of the scapula. Injury of which of the nerves A to D is most likely responsible for the deformity shown in the picture. In the picture, the medial border of the right scapula appears to be projecting backwards, giving the appearance of a wing as the patient presses against a wall. This condition is called winged scapula. The deformity results from serratus anterior muscle being paralyzed. This muscle forms a flat sheet that wraps around the thoracic wall and is attached to the anterior aspect of the medial border of the scapula. So when the muscle is paralyzed, the medial border of the scapula projects backwards, producing the winged scapula. The muscle, serratus anterior muscle, is supplied by the long thoracic nerve, which is a branch of the roots of the brachial plexus. Now, if we look at the dissection and try to find the long thoracic nerve, then the nerve is located on the lateral aspect of the thoracic wall, almost at the mid-axillary line, and it lies on serratus anterior muscle, which it supplies. The other nerves here are D is a branch of the posterior cord of the brachial plexus that continues here to supply latissimus dorsi muscle. You can see the tendon of latissimus dorsi, ribbon-like tendon. And the other nerves here can also be identified by recognizing the presence of the capital M shape that is related to the cords and branches of the brachial plexus. So here, this nerve, which is not marked as the musculocutaneous, one of the limbs of the M, and here this is the median nerve formed by lateral and medial roots of the median nerve, and this limb of the M is a branch of the medial cord of the brachial plexus, and that is the ulnar nerve. All these are not related to serratus anterior, not related to the winged scapula. It is the C that is the long thoracic nerve, which supplies serratus anterior and when injured results in winging of the scapula. Which joint is dislocated in this patient? We can see here that there is a high step is visible at the region of the acromioclavicular joint, indicating a dislocation of the acromioclavicular joint. A severe fall on the shoulder tears the strong conoid and trapezoid ligaments that connect the inferior surface of the clavicle to the coracoid process and are important for the stability of this joint. And if they are torn, then this results in dislocation of the clavicle from the acromion, as we see it here in this patient. Identify the vessel A. This is a close-up view of a dissection of the axilla with the axillary artery here. Artery A arises from the axillary artery. It arises from the axillary artery distal to where pectoralis minor, the muscle which has been reflected up here. This is the location, normal position, location of pectoralis minor muscle, and it divides the axillary artery into three parts. A part that is medial, and this is the first part. A part which is posterior, which is the second part, and the other part is the third part of the axillary artery. So this branch A is a branch of the third part of the axillary artery that is distal to pectoralis minor muscle, and it passes through the posterior wall of the axilla through the quadriangular space, and we can see it here accompanying a nerve. Not the entire extent of the nerve is shown because the nerve arises from the posterior cord of the brachial plexus behind the axillary artery. It's a big nerve, the large terminal branch of the posterior cord of the brachial plexus together with the radial nerve. Radial nerve can be identified here being large, posterior, and related to the glistening ribbon-like tendon of latissimus dorsi muscle. And B is the axillary nerve. It disappears immediately from the axilla by passing through the quadriangular space accompanied by the posterior circumflex humeral artery. A 25-year-old lady presented to the ER after falling while changing a ceiling lamp. Radiographic examination attached shows a fractured left clavicle in A. Which muscle is attached to the medial end of the clavicle that causes elevation of the medial bone fragment? So the radiograph shows a fracture of the clavicle at the weakest point, which is located between the medial 2/3 and the lateral third of the clavicle. This is the point where the bone changes from a rounded thick section into a flattened thin section laterally. Now when the fracture occurs, trapezius, which is attached to the lateral third of the clavicle, will be unable to hold the weight of the arm. So the characteristic picture of the patient with a fracture of the clavicle is that of a person supporting his sagging upper limb with his opposite hand. The medial fragment is drawn upwards because of the attachment of the sternocleidomastoid muscle from the neck, which is attached to the medial end of the clavicle and the sternum here. So that's why it's called sternocleidoclavicle, and then mastoid attached to the mastoid process of the temporal bone. So it's the sternocleidomastoid muscle that elevates the medial fragment in this fracture. We can also note that the lateral fragment is not only depressed but is drawn medially, and this is by shoulder adductors. Principally here is the latissimus dorsi and the pectoralis major muscle, which are attached, both of them are attached to the proximal end of the humerus, to the intertubercular groove and its lips.